Thank you. Thank you for the opportunity to present these preliminary results. My name is Tanya Lam. I'm from the University of University of British Columbia. I'm from Alberta, in Vancouver, Canada. I have nothing to disclose. So actually, my area of interest for research has been on gait rehabilitation after spinal cord injury. And for many years in my lab, we have been focusing on using robotic exoskeletons on the training various aspects of functional recovery after spinal cord injury. A few years ago, we started working with the exoskeleton, which is a robotic device for overground training. And as we started conducting studies with this device, many of the participants would just spontaneously and independently tell us that, my bladder feels less irritable, I don't leak as much, and they attributed it to starting the exo training. Now, bladder management in spinal cord injury largely relies on medical intervention, and unlike other populations that are dealing with incontinence, there's not much consideration about exercise-based therapies for people with spinal cord injury. One of the possibilities for this is because we might be missing some of the potentially spared motor function in the trunk muscles. So those of you who might know about neurological assessment of spinal cord injury, the assessment of the thoracic segments are just based on sensory tests, and the motor function is inferred from those results. And in fact, we are probably missing some functional sparing of the muscles in the trunk. And indeed, we have found this in our lab. Over the last few years, we have done a few studies showing that we are able to detect, using electromyography, activity in the trunk muscles from individuals who are rated as motor complete with complete paralysis at high thoracic or cervical level injuries. And these are examples from individual subjects. Now, going back to the exoskeletons, you can see quite clearly that one of the big differences between the Locomat and the exo is that with the exo, individuals have to actively shift their weight and use their trunk muscles in order to trigger each step. And when we record the EMG activity of these trunk muscles, comparing Locomat walking with exo walking, you can see very nice recruitment of the abdominal muscles in somebody with a motor complete injury. And in addition, in this person, we also recorded using surface EMG from the pelvic floor muscles. You do see a bit of movement artifact, but you can also clearly see the rhythmic muscle bursting in these muscles with exo walking. And so we are then asking the question, can exo-assisted gait training improve lower urinary tract symptoms in individuals with complete spinal cord injury? So we are continuing the study, but we've been recruiting individuals with chronic spinal cord injury who report the presence of some lower urinary tract symptoms. And we randomize them to receive either Locomat or exo training for 12 weeks. And some of the preliminary data I can just show very quickly. So far, we have randomized 5 individuals, and we have results from 1 individual who completed the exo training and 2 individuals who were in the Locomat training. With the urodynamics, we saw a reduction in detrusor pressure in the 1 individual who completed the exo training, but otherwise no other apparent changes. Using the Qualavine questionnaire for measuring quality of life and lower urinary tract symptoms, we see in general that participants in the exo group tended to report stability or maybe improvement across the 4 domains of the Qualavine, while the participants in the Locomat reported the same or worsening of symptoms. So we are excited for the possibility of using the exoskeleton as a possible way to activate the pelvic floor muscles in people with spinal cord injury. Our preliminary results to date are still early, but we are excited for continuing this work. And also, if you're interested in learning more about the potential for muscle sparing in the pelvic floor, I invite you to attend my students' talk tomorrow. Thank you for your attention.
Thank you, Tanya. We may have time for 1, maybe 2 questions. Thank you.
Thank you very much for interesting study, Švihra, Slovakia. How do you explain such changes according to urodynamic investigation in spinal cord injury that you showed us such detrusor pressure were decreased? Because me as urologist, we have all problems how to decrease such bladder dysfunction. Mm-hmm. Do you believe there is some connection through new fibers, or how to explain it? Because it's really very unknown mechanism for me.
So we know that there are some neural connections, pathways between the pelvic floor skeletal muscles and the detrusor muscle of the bladder. So there are some reflex pathways that have been identified. So that is one possibility. The changes in the tone of these muscles or activating them might be changing the properties of the bladder. But I really would like to resist saying too much about the urodynamics, first because I'm not a urologist, and second, this is just, very few subjects, and so I would rather reserve any other.
If that's true, I can congratulate you, and maybe we can diminish Botox treatment. I don't know.
Okay, it's just really information, but I know in the UK there's some very elementary work, if you like, done at Salisbury Spinal Cord Injury Unit, and they have come up with the same thing, which can't explain that complete spinal cord injury patients who can actually activate some fibers in the pelvic floor. Mm-hmm. So it's just for information for yourself.
Great to know. Thanks. Okay.
Time for one quick question.
Sorry, thank you for the presentation. You mentioned motor complete spinal cord injury patients, which means that there are, I don't know if out of the 5 patients, some patients who already have sensory sparing in their sacral segments. And by definition, there is some sensory sparing, so there may be some sensation, at least sensation in the bladder.
Yes.
Without, looking at the data. The other thing you mentioned about changing the detrusor pressure. So where actually and which part of the detrusor pressure? Did they have detrusor overactivity before? Is it the starting pressure? Is it the end filling pressure? I would like to know more.
I will have to defer to my urology collaborators for that question. I apologize. Yeah, thank you.
Thank you, Tanya.